Speaker, Dr. Sanjay Chaudhary, who heads I7 Chaudhary Eye Center Group of Hospitals, a very leading cataract refractive surgeon of our country. And he is going to tell us something realistic also, PHAKIC IOL complications. So let's hear from him.
Thank you, ma'am. So we have discussed a lot of pros and cons about the PHAKIC IOLs. So let me take you through some complications, some common and some uncommon complications. Cataract, of course, we have all talked, but why I'm trying to show you this slide is the discussion that a low vault or a place where the PHAKIC IOL is touching the anterior surface of the crystalline lens is liable to create a cataract. So here you can see the low vault, and when I dilated the pupil, you can see the entire profile of the ICL. In the center, it's a very shallow vault. At the periphery, it is touching here. Now we're in a dilemma. This is a very old slide, almost about 12, 13 years old slide. When we were in a dilemma, what should we do? Should we take out this lens and put it by a lens which is one size higher, or let it be? The patient was so satisfied that we decided to continue. We called him for a 1-year follow-up, and this is on the 5th follow-up. At 5 years, he developed, at this point, a small speck in the anterior capsule, and on a dilated examination, you can see an anterior subcapsular cataract. Now, at that time, again, we were in a dilemma. Can we stop the progress of this by changing to a higher size and increasing the vault? Or should we let it be because the patient is so happy and it is not in this opacity is not in the center? Why should we manipulate? So we let it be, and I don't have that third slide now, but at about 10, 11 years post the initial surgery, the patient did develop a significant amount of cataract, and we had to do a cataract extraction. So he lived 11 years very happily with this. At that time, when I operated on him, he was about 25. Now he was about 36, getting closer to the presbyopic age. So maybe I felt that I did the right thing by not actually changing his lens at the first instance. But of course, it is a subject of debate. Lots of people, the experts, do believe that it is wiser to change it in the initial stage so that the patient may enjoy a better vision for even more than 11 years. The question is always about aquastasis. That is one of the chief cause of a cataract developing under the ICL, and a central hole has done wonders to all this. So we have discussed that in detail. Now here's another very interesting situation. Visco on the crystalline lens. So when we see these slides like this, we say, oh, there's a visco on the lens and it will slowly go away. And in many a situation, it does. So this slide, you can see on the left is a slit lamp. On the right is a diffuse thing, a deposit. We felt that this is again a very old slide, about 6, 7 years back. We thought it's a visco on the crystalline lens, and we followed it up, and in about 3 months it almost faded away without any visual loss. So we were pretty happy that visco did come and go, but then we thought that if visco is getting deposited, why not encourage doing ICLs without visco? That is when we entered in a heavy way in doing hydro insertions of ICLs. And in the hydro insertions, we came across this situation once. Again, if you see the right slide, it looks as if there is visco on the crystalline lens. I said, now where does this visco come from? And the left side, again, there's a little faint deposit on the crystalline lens. Now that we are doing a hydro insertion, where is this coming from? So we were taken a little by surprise that we need to have some other answer for this kind of a situation. But then at day 10, again, on the left side, you see on the slit, this opacity started dissolving. On the right is a diffuse image of this started dissolving. And at 30 days, also it had almost gone off with hardly any visual defect. So we were satisfied, but we really couldn't find an answer. Till again, we had another situation, hydroinsertion, and this kind of a deposit on the crystalline lens. Now, at that time, we OCTs were there with everybody, and we did think of doing an anterior segment OCT in these patients to see what is happening. So this was the first post-op day, such a big deposit. And at 6 months, the periphery had almost cleared up. You see this. And this opacity had kind of concentrated in the center as a ring. And when we took an OCT picture, the vault is very good. Now, this is the anterior capsule. This line here is the epithelial layer, which appears that this is causing a proliferation or vacuolation of this epithelial layer and a cataract with a central large vacuolar area. So this is definitely subcapsular and not in front of the capsule. So this was then we looked up the literature and we found a paper which was a mind opener. It very clearly said that in implantable collamer lenses, after the irrigating procedure through the narrow space between the ICL and the crystalline lens, that means if you are very vigorous and you want to irrigate under the ICL for some reason, and the result shows on OCT bleb-like lesions in the anterior subcapsular space.
Sir,
So you
1 minute
have what is
remaining.
called, sorry?
1 minute. No, it's okay. Yes.
Yeah. So you have a vacuolar kind of a reaction in the subcapsular area. And we found in our cases, in the last case, that first it was diffuse, flat all across the anterior capsules, sub-anterior capsular, and then it cleared up from the periphery, got accumulated in the center. So if you look at this slide, initially it was spread all across, a diffuse, even whitish haze under the anterior capsule. And over a period of time, the periphery cleared up and it kind of humped up in the center as it appears in the left eye. So from what in this you have to learn is that you should not irrigate in the space between the crystalline lens and the ICL. Avoid it as much as you can. In fact, it should be a totally out of bound area. And if you can get away with the least amount of irrigation in the chamber when you're putting in a phakic IOL, the better. So that is why now my current technique is that I use a Visco in my injector because that gives me a controlled injection. I still do a hydro insertion. Then there's a little Visco in the anterior chamber, both in front and behind, in about 5 to 6 seconds with a bimanual irrigation aspiration cannula. I remove the Visco in front of the ICL. I do not go behind the ICL at all to take out that little bit of residual Visco. And fortunately, for the last few months, we have not faced a situation of these subcapsular vacuolar changes. They could happen again. I don't know. When I do get it, I would definitely report it. So this is just to show that when you use a Visco, you tend to aggressively remove the Visco, and the recommended time is almost 1 minute, both in front, and because the Visco is also behind, You try various techniques. This is what we were trying at one time when you were trying to push the irrigation through the central hole. And we thought that was a great idea to get the Visco out from under the ICL. A thing we would not dare to think of now. At that time, see what I was doing and a couple of other people were doing. And we thought we have got all the Visco out, not realizing that this jet is hitting the anterior capsule. And this is the kind of a watermark, we called it at that time, on the anterior capsule. This totally disappeared in about 1 to 2 days. But the idea is, please avoid irrigation in a phakic IOL as much as possible. Here's another very unique condition, a pigment storm. Now, this was such a new thing, not mentioned anywhere in the literature. Huge amount of pigment coming out from the central hole, blurring the vision. The vision suddenly dropped from 6.6 to 6.36. And we were surprised. Now, what is this? I'm going to play the video again. We called it the pigment storm. See the way the pigment is coming from behind the ICL space through the central hole into the front area of the ICL. The surgery was uneventful, and this happened approximately 15 days after an uneventful ICL surgery. We probably, since it was coming in from behind to front, we attributed it to a pigment release from an area where the ICL was rubbing the root of the iris or the ciliary body and causing a lot of pigment release, and probably some kind of a cyclitis. So we put this patient on cycloplegics and Predfort, and in 2 days' time, just in 2 days, it recovered. And this video is about 4 months back, and we have not had a relapse. Now, this is just a conjecture, a speculation that the root of the iris or somewhere there was a lot of pigment release on the 15th day. I have not been able to see any literature which is giving me an explanation on this, but it responded very well to cycloplegics. A high vault, we already discussed in detail.
Dr. Rajesh, I'm sorry, Dr. Sanjay, you have to conclude.
Yeah, so high vault, I'm not talking about much. We have discussed halos, we have discussed smaller toric rotation, we have discussed. And I think with that, I'll conclude the talk. Thank you, ma'am.
Yeah, very interesting talk and different things which you brought out to our notice. I would take your question along with after Sri Ganesh's talk, so that he's already